system has the kidney, and one of the power of the kidney is that it's a great way to get rid of your nitrogenous compound, right? And those are your urea, uric acid, um, creatinine, and very important that you know the term azotemia versus uremia. So when your kidney cannot get rid of this nitrogenous compound, most likely your BUN, we call this blood urea nitrogen, will be increased. And that is known as azotemia. And, and azotemia is a little bit different from uremia, is that the person BUN increase suggested that there's kidney problem, but there's no sign and symptom yet. In uremia, is that when a person gets uremic stage, they vomit, they have profuse sweating, and they have diarrhea. Okay, so the kidney, while the kidney does a number of functions, I told you, think in the context of a big C, right? How it regulate your blood, involved in making vitamin D for absorptions of calcium through the small intestine, involved in glucogenesis, detoxify some of the drug, eliminates nitrogenous waste, regulate sodium and potassium through the aldosterone, and then it controls the pH of our body, for example, because the kidney can get rid of the hydrogen ion directly, as opposed to the lungs who does it indirectly. Okay, and I believe that you guys should know now the blood flows into and out of the kidney. Good way to remember them as REAIA into the glomerulus and then epi-air. Okay, and this is essentially just showing you that it's an acronym. A here is for aorta. Aorta brings blood into the renal artery. Segmental artery is the next segment, but then you have the interlobar, right? These would be interlobar into arcuate, so come across. Arcuate arteries are found between cortex and the medulla. Then it branches into the interlobular. So interlobular will find in the cortex, into the afferents arteriole, into the glomerulus, and from the glomerulus out into the efferents arteriole. Efferents arteriole branch into the peritubular capillary, into interlobular vein, come back down as arcuate vein, interlobar vein, and renal vein. Okay, and the functional units of the kidney that does is three major function, which is to form urine. The three processes that are involving urine formations are filtration, reabsorption, and secretion. Okay, those are really three major important functions of the functional unit kidney, which is known as the nephron. So the nephrons start here. So this inside the glomerulus, inside this knot is the glomerulus and the Bowman's capsule surrounding that. And the Bowman's capsule, then, in other words, your blood is going to get filtered, and the filtrate flows into the capsular space, which then flows into the proximal convoluted tubule, goes down to the collecting duct, into the distal convoluted tubule, and then out. Okay, so a lot of these are collecting duct, and then it goes out. So in fact, in the collecting duct is where you first see the urine, but usually filtrate is flowed in the nephron. So here is a important structure of the kidney, right? So this is where the first function of the urine formations occur, which is filtration. Filtration is in the glomerulus, and the visceral layers of the Bowman's capsule. So that is very important to note. Okay. So if you take a cross section of this, and you will see that here would be the glomerulus, if you will, or which is a ball. The glomerulus here shows you is a ball of capillary. Right? So if you take a capillary here, inside you have your red blood cells, your protein, and the question in the future might be is what constitute the filtration membrane. The filtration membrane has three important parts, which is the endothelial layers of the capillary, the basement membrane, and then the visceral layers of the Bowman's capsule. Okay, the visceral layers of the Bowman's capsule. Okay? So here's the basement membrane, and this visceral layer, right here, visceral layer, epithelium, basement membrane, okay, and the endothelium. So that's the component of the filtration membrane. And a lot of renal pathology is associated with the glomerulus. In fact, here, okay, and how you can have either the expansion of the endothelial layer, you can have immune cell recruited this, and because when we talk about different types of hypersensitivity, and hypersensitivity type 2, for example, is where you have antibody that bind to the cell antigen, okay, directly. In fact, we do see that, glomerulonephritis could be due to autoimmune disease that binds to self antigen, particular in this area. Okay, almost like type 2 hypersensitivity, as well as type 3 hypersensitivity. Type 3 hypersensitivity is antigen antibody complex that is circulating. And when that complex circulate, where do they go? They go to the kidney, right? Trying to get filtered, but because this filter membrane is so small, it can't filter the complex, and the complex end up being in around here. And over time, it will damage that. Okay. Notice the in between the glomerulus and the endothelial layers of the blood vessel and the visceral layers of the Bowman's capsule, as you can see here, are these cells known as mesangial cell. Okay, so they really play important regulating in terms of causing the afferent arteriole to constrict, which is the way in which the kidney auto-regulate how much filtration. The problem is that if you have too much filtration, you lose a lot of fluid, and you could get dehydration. If you don't have enough filtration, then your waste can accumulate in your body, and then you can develop azotemia and uremia. And so the kidney does auto-regulate itself if you have too much filtration as part of the juxtaglomerular apparatus involving the mesangial cell. Okay, now the three different processes in urine formations are, as you can see here, is that filtration is very important. Okay, and this once your blood get filtered, so most of this content that is finds in the blood plasma, particularly if they're small enough, not protein. Protein is too big, but glucose, sodium, potassium, all that thing will get picked up. So we call this reabsorption, and reabsorption occurs in the proximal convoluted tubule. Okay, and because a lot of these cells involve in active transport, and so they will have a lot of mitochondria, and mitochondria rely on ATP, or mitochondria generate ATP, but it relies on oxygen and glucose involving cellular respiration to generate a lot of ATP. So when the kidney deprive of this oxygen, the cells in a proximal convoluted tubule is very sensitive. If it's hypoxic, these cells will die. Okay, and as die, they're going to come off defacement, if you will, into the fluid, into the urine, and we can see that in the urine, right? So acute tubular necrosis is due to two important things: either ischemia, right, not enough oxygen to support it, or nephrotoxin. What that means is that particularly a person who having an angiogram and image of their blood vessel, where they may take things like contrasting dye, and when they take that contrasting dye, the dye is going to get filtered, but some of those dye could be toxic, and if it's toxic, it can kill the cells, as you will. Okay. And then so filtration, reabsorption, and then you got secretion, which is the third process in which the drugs and a lot of compound gets secreted from the distal convoluted, from the peritubular capillary directly into the distal convoluted tubule. Okay, and creatinine, for example, get secreted from the peritubular capillary into the distal convoluted tubule. So one of the ways to measure the kidney function is to look at renal clearance. And most of the time, renal clearance is equal to glomerular filtration rate, which is about 125 ml per minute. Okay, but so in other words, if the kidney can remove maximum 125 ml clear of some substance, right, in 1 minute. That's the maximum, 125 ml, which is equal to its filtration rate per minute. In that case, like let's say inulin, if you have inulins in the blood, inulin is removed from our bodies about 125 ml per minute because inulin is not getting reabsorbed. Okay, and it's not getting secreted. The kidney cannot remove glucose if your blood glucose is about 100 milligram per deciliter, because most of the glucose that get filtered get reabsorbed completely. So glucose does not end up in the urine unless your blood glucose level is really high, like 400 milligram per deciliter in the case of diabetes mellitus, which then overrides the transport rate. Okay. Now, the renal clearance of creatinine, for example, is 140 mLs per minute. And that means that filtration itself is removing 125 ml per minute, same as glomerular filtration rate. But about 15 mLs per minute, the creatinine is secreted from the peritubular capillary into the distal convoluted tubule. So when you talk about renal clearance of creatinine, is about 140. All right. So when we're talking about disease of the urinary system, typically in the kidney, you will see a lot of them is glomerular disease. There are some cancers, of course, like any organ system you can have. Cancer, important thing that I mentioned to you earlier is that renal tubule are metabolically active. And so if it's deprived of its oxygen, it will die, right? So we call that ATN, acute tubular necrosis, or because it's filtering toxic compound, and that toxic compound is actually killing those cells. Other terms that you often people use in the clinics, dysuria, pyuria. So a normal person on average should produce about 2 liters a day, okay, of urine. You might filter, if you calculate that filtration rate is 125 ml per minute, right? And if you calculate that, that comes out to about 180 liter a day. Okay? Almost 200 liter, but only 2 liter is being passed out of body, okay, as urine. Okay, so that means that 99% of the filtrate get reabsorbed. So 2 liters is a normal number. Now, if it's less, then it's going to be a problem. Dysuria, diuresis, basically just go to the bathroom. Some of the urine might have pus in them, so that suggests it's bacteria. Some of them might have blood, and the blood could be usually hard to see. So we call that occult hematuria, or you can see a lot. When you see a lot, then that's usually could be suggesting cancer. Occult is usually oftentimes you see in nephritic syndrome. So I will tell you the difference between nephritic and nephrotic syndrome, and that's how to distinguish between different kinds of glomerular nephritis. Nocturia, so people go to the bathroom at night, not because the urine is spot. Oliguria mean not a lot, right? So few, so 500 or 500 ml or 1,000 ml. So that means just low. Proteinuria is very common in terms of nephrotic syndrome. So if you see a lot of protein, you will see that proteins in the urine. That's definitely due to the damage of the filtration membrane. The filtration membrane, again, is composed of the endothelial layers of the glomerulus, the basement membrane, and the visceral layers of the Bowman's capsule. That filtration membrane usually cut off so that protein should not passing through. Albumin should not be passing through. If you see it is passing through, then it is damaging filtration membrane, and you will see proteins in urine. Glycosuria, typically seen in diabetes mellitus, type 1 or type 2. The difference is that type 1 is a juvenile, type 2 is adult onset. Usually an obese individual, they produce them, but they're resistant to insulin. Insulin oftentimes tells the skeletal muscle to express glucose receptor, and thereby the cells will import glucose. Thus, the blood glucose level will goes down. Acetomiuremia, I told you bun level is high, no sign and symptom yet. Uremia, you will see sign and symptom. Acute nephritic syndrome, often see in post-strep infection, for example. Nephrotic, so the difference between nephritic and nephrotic is typically you have occult hematuria, right? And so in my question to you in the future is that be able or be prepared to distinguish between nephritic and nephrotic, right? And when I say, the proteins in urine, proteinuria, let's say 4 milligram, right, which is a lot. Typically, it should be like around, it shouldn't have any protein, but you see a lot of protein. Sometimes, if you don't want to remember the number, I just say plus protein. That means there's a lot of protein there. And then that's you should think of is nephrotic syndrome. Kidney can also develop nephrolithiasis, and I show you how that could be associated with hyperparathyroidism, right? So you can remember related to 3 things, which are bone stones and psychic bone. But there are other causes of kidney stone, okay? Just calcium, too much calcium. Grace?
So the nephritic syndrome is related to hematuria. Is that what you were saying?
No.
Okay.
Okay, so hematuria means blood in the urine. Okay, and blood in the urine is often associated with nephrotic syndrome, which is this. Okay. Nephrotic syndrome is where is related to this. Okay. This is a general term for a kidney stone. And kidney stone is related to hyperparathyroidism. Right? So basically, you have too much PTH, your blood calcium level is very high. PTH stimulate osteoclasts to chew up bone, and too much calcium end up in the kidney. You can develop kidney stone, and then too much calcium can interfere with neural. Okay. Does that answer your question?
Yes, thank you.
All right. Now, so oftentimes we can also look for components within the urine. These are known as CAS to suggest to tell us something about the kidney or disorder related to these kidney. So your urine should not have any bacteria in there, right? If it is, then of course you have infection. Okay, that's and a very common infections of the urinary tract is ascending bacteria, E. coli. Okay, so that's a nice, easy exam question. A guy has a urinary tract infection, where it come from? Most likely it's going to be E. coli. White blood cells related to bacteria could be related to cancer, right? Red blood cell class, red cell cast. This is oftentimes you might see a lot of blood in the urine. Again, when you think about blood, uh, think of nephritic syndrome. Protein cast, you think of it's more nephrotic syndrome. Red blood cell cast cluster or red blood cell, uroepithelial transitional cell CAS, can be cancer, we'll see. And there are some crystal, as you're going to see a little bit, that they're in cells that they essentially, this is congenital defect in which how they have too much oxalate, and then oxalate can form bind with calcium to form crystal. So that's usually, if you see that, that's congenital disease. Okay. Other casts, like you see these right here, white blood cell cast, tubular cells cast, and muddy brown cast. Tubular cell cast here, that suggested that um, the defacing of the renal tubule due to ischemia or nephrotoxin. So acute tubular necrosis is often, so anytime when a clinical question that tells you that you might see a muddy brown cast or tubular cast, you think then it would be due to the defacement, denucleation of the tubular cells. Okay. Um, Now, interestingly, you also see a lot of fat. Okay, and we're going to see that the nephrotic syndrome is caused by a lot of proteins in the urine. If you see proteins in the urine, right, pathophysiology, then what happened is that your albumin should not be in the urine. If you lose albumins in the urine, your protein level will be low. So it will be um, hypoproteinuria, if you will, hypo, right? Low protein. And so the kidney essentially is trying to make more protein, right? And with trying to make more protein, it also makes a lot of lipid as well. Okay. And so therefore you see oval fat cells. Right? So when you see that, think of it as proteinuria. Okay? Other cast summarizes here tubular cell class. That's definitely acute tubular necrosis, um, granular cast, as well as muddy cell cast, red blood cells, glomerulonephritis. But then that's a general term. In a little bit, what I hope you guys are going to do is to go study. I have made it a table to show you how you would distinguish between different types of glomerulonephritis, whether it's nephritic or nephrotic. We're going to go over that a little bit. And remember that overcells fat always oval fat bodies cast associate with heavy protein in the urine, right? One more time. Um, Nephrotic syndrome, lots of protein. That means the body losing the protein, the liver trying to make more protein in the process, make more lipid. Okay. All right. So some of the syndrome of renal disease are, some of them is chronic, some of them is acute. Post-strep will be acute, is onset. Chronic would take longer time, like polycystic kidney disease. It's progressively, it's considered chronic. Urinary tract infection, urinary tract obstruction can lead to hydronephrosis and occult proteinuria, which means it's hard to see, okay? And in this case, occult proteinuria, and people often describe it when you start seeing some protein in the urine, um, that's clinical. That's the first clinical sign of someone has diabetes, okay, diabetes nephropathy. Okay, so that's also a good thing to note too. Proteins in the urine. Uh, there are other glomerulonephritis, but you can't rule out that it's diabetes either. Okay? And because we have so many Americans who are diabetic, and the frequency uh, of people who has diabetic neuropathy and nephropathy is to think of it as um, protein related to diabetes. Okay? Again, it's part of nephrotic syndrome. Okay, so we're going to talk about some congenital abnormalities, some acquired cystic kidney. Glomerular disease is a big, huge one, and some of the disease of the interstitium is part of the congenital abnormality. Renal stone, not going to talk about too much, and then there are some, and then we're going to talk about hydronephrosis. The word hydronephrosis really means distension of the collecting system, which is from the collecting duct. So your collecting duct is a structure that typically collect urine, and it's then bring it to the renal papillae, which then empty into the minor calyx, to the major calyx, to the renal pelvis, and ureter comes out into the urinary bladder, and from the urinary bladder goes out to the urethra. Okay. So this hydronephrosis means that those particularly the ureter is distended. Okay, that's what it means. Hydronephrosis. Typically, you can think of it as related to obstruction, but there are other cases where it's not related to obstruction. All right, so congenital disease. Congenital disease, there are typically children who are born that might have normal nephron, which is the glomerulus. The nephron doesn't have the glomerulus, but they may have the glomerulus normal. So nephron starting from the Bowman's capsule is normal. Proximal convoluted tubule is normal. Collecting duct is normal. Distal convoluted tubule is normal. Collecting duct is normal. But the interstitium has scarring, okay? And thus it's interfere with the normal function of the kidney. And if it's congenital, usually it's in utero development and fetus development, particularly in the latter half of the pregnancy, the fetus is inhaling the amniotic fluid. And then if you have normal function kidney, you may have urea, for example. It's part of the amniotic fluid. And so by taking in that urea, it helps normal lungs development. And if the kidney is not doing its job because of the kidney failure, because of the parenchyma disease, the lung is not going to develop as well. Okay. All right. So there are many cases that can lead to hydronephrosis, and you should think of what are some of the ways that could lead to obstructions of the fluid, flow. Obviously, if they're, you should know that for now that urine flow are in the order, okay? Collecting duct to the renal papillae, minor calyx, major calyx, renal pelvis, ureter, urinary bladder, and the urethra. Okay, so obstruction anywhere from the pelvic ureter junction, ureter vesicle junction, even the urethra could have its own additional muscle development, tissue develop, so that in the urethra themselves can causes that obstruction. What are some examples in which how one can have distended ureter, for example, without obstruction? Well, there are actually a couple more cases besides Poon belly syndrome, is in which the children who are born without abdominal muscle. Okay, and so the urinary bladder is flaccid, and it's harder to expel the urine. So therefore, typically the urinary bladder will get filled really, and you can have a incontinent is very common in Poon belly children. Or you can have vesicular ureter reflex. And what this is that the ureter typically insert into the urinary bladder at the base, near the base of the urinary bladder. And so the wall of the urinary bladder itself is preventing urine from backflow into the ureter. But in some cases, you have a defective insertion. Therefore, you can have a backup of the urine. Cystic disease, like polycystic kidney disease, is a chronic infection. Is a chronic condition, and oftentimes that you see develop in the kidney, and they start out progressively. And polycystic kidney disease often sees in male around 30 or some, 30s or something. A male will have renal failure. right? And so typically, if you look at easy way to determine is that creatinine level, right? So normal functions of creatinine level, for example, is 140 mLs per minute. That's just a general calculation. But in these people, you can track them and say, oh, in their teens, their renal clearance of creatinine is 90. So in other words, typically you should be able to clear 140 mLs of blood free of creatinine, but they only can do it, let's say 90. Okay. So that will be like the first stage of renal failure. And then in the 20s, for example, they only can remove 60 ml of creatinine per minute. And then that's like stage two. Stage three and stage four, stage three might be now they only can remove 30 ml, right? And then stage four is like 15 or cannot remove any creatinine from their blood. Thus, that's the end-stage renal failure. Uh, and end-stage renal failure, meaning that that person has to have kidney transplant or goes to dialysis 2 or 3 times a day, sorry, 2 or 3 times a week to remove the waste from their blood. Some metabolic disease, we only talk, there are many, but we only talk about two, um, which is oxalate and cystitis. Okay. All right. So here are some of the example of congenital defect. Parenchyma disease, a disease that often sees in the interstitium. Okay. So they have normal nephron and everything. Okay. And by the way, if I didn't tell you that one of the functions of the loops of Henle is to concentrate the urine. So anyway, in these uh, children who have parenchyma disease, they cannot concentrate the urine, so they end up losing a lot of fluid. Okay. All right. Now, in the case of uh, hydronephrosis, you see hydronephrosis, and it could be unilateral, one side, or bilateral, two side. You should think of several places where the these obstruction might occur. The obstruction could occur here, so we call that is the pelvic, renal pelvis, and the ureter junction. So you can say that the P U J pelvic pelvic ureter junction, right? That's one area. It could be also here. Well, this is known as ureter vesicle junction. So it's ureter vesicle junction, right? Or you can have posterior uteral valve. Posterior uteral valve, that's basically a mass that is grown in the urethra, so that blocks it. And yeah, so then you have all these backup. Okay, so in case of, I think I also have two more in the okay. So where are we? The oh, here's a baby that are born with prune belly, so they have no abdominal muscle. Oftentimes, this thing will get distended; it actually come out, and so because the maturation reflex typically the um, as the urinary bladder that get enlarged, right? Um, can you guys hear me? There seems to be something wrong.
Yeah, we can hear you.
We can hear you.
Okay, good, good. You just can't see me. I think I'm frozen. I yeah. Okay, so typically I was going to show you, but I can't. It looks like it's frozen. Um, Now, in this case, what you see is that in the children who have prune belly, they have no abdominal muscle. So when the urine is flowed into the urinary bladder, the urinary bladder typically, if it's confined within, in the abdominal pelvic floor region, it can push against the wall and it will stimulate the maturation reflex up to the um, um, medulla oblongata, which then sends the information down via the parasympathetic to know that the bladder is full, so then it could be time to void, for example. But in prune belly, you don't have that maturation reflexes working, and oftentimes the urine just stores in urinary bladder until it get full. Then you get incontinent. The child cannot control it. And so, parents with prune belly oftentimes can do is you just kind of remind the children, hey, it's 2 o'clock, you have to go to the bathroom, right? So then people will know uh, at the regular interval when to go to the bathroom and so forth. Okay, so in the vesical ureter reflex, which really means that here's a ureter inserted into the base of the urinary bladder, and the muscle walls usually prevent it, but in some cases there's a defect. So then there are the urine can actually backflow, and here just shows you different degree of the reflex. Typically grade 5, I mean, it's just full. This is over progressive uh, in older kids, for example, whereas they start out as grade 1, which is a little bit, but then it slowly goes up in grade 2. And then by the time it reaches the minor calyx, major calyx, that could damage the kidney over progressive time. Okay. Um, mm, Okay, I wanted to add a couple more things regarding obstruction uh, without, can I go back? Okay, so obstruction, sorry, hydronephrosis without obstruction. Okay, uh, another example would be, say, neurogenic bladder. So in neurogenic bladders is often associated with the spinal bifida. And in the spinal bifida is where developmentally the vertebra do not fuse together, if you will. Okay, so as such, the spinal cord will come out of the vertebral column, and so you get a pouch, if you will, a spinal bifida, and thus there isn't any neural stimulation. There's no nerve that is coming from the urinary bladder. Therefore, you can get a distended urinary bladder without knowing. So that's neural. That could cause a hydronephrosis without obstruction. And then another one I would say you can add is known as uracil. Okay. Um, uterocil. Okay. And then in uterocils, usually what it is it's congenital, but the distal portions of the ureter, it just enlarged. And and therefore it actually get a lot of urine flows down there. And then it's actually at the distal end, it's balloon up, if you will, before it flows into the urine, into the urinary bladder, and that can cause hydronephrosis. Okay, so there are many other genetic metabolic disease. Here, this one just shows you the polycystic kidney disease, right? So this is a good example of someone who has long-term consequences of potentially developing or will develop a renal failure. As you can see, the cysts, and this is due to a mutations in polycystic kidney disease gene. It's inherited as dominant, recessive dominant, and what you see is here, and over time the cyst can pop, and every time it's pop, it's very painful for the boy. Okay. Two metabolic disorder I want you to think of as cystinosis. And cystinosis, in which how the amino acid cysteine accumulate in the cells. One of the common thing is that they started to develop kidney failure early on. And because the kidney failure, they lose a lot of sodium, potassium, and calcium as well. And so developing, if you have low level calcium, you can have rickets, like bow-legged boys and stuff like that. That's the typical rickets. Also, another example is acidosis. Acidosis is a essentially isolated crystal. It's one of the casts you often see. But in this disease, the liver doesn't have the enzyme to break down acetoacetates. And the acetoacetate is in essence can form crystal. And this acetoacetate crystal can deposit everywhere, okay, not just the kidney. But the kidney is problematic, and in this case, you can't have kidney transplant because the new kidney comes in, you still would have that acetate crystal over time will deposit. Other mitochondria, cytochrome C, and so forth. But we're just going to say these two is the metabolic disorder, okay, associated. Okay, so before we're going to take a break, I'm going to set it up so that you have to remember these glomerulus disease, okay? So the majority of the pathology associated with the kidney is due to the glomerulus. Okay, that's so critical. And glomerulus, you can basically break down into these two things. Nephritic syndrome or nephrotic syndrome. The key difference between these two is nephritic is you will start seeing blood in the urine, whereas nephrotic you see proteins in the urine. Okay, minimum changes is part of the nephrotic syndrome. We're going to talk about a little bit. In adults and children, typically it may have acute no urine output, and then all of a sudden it's fine the next day. Yeah, I'm going to see if I can try to fix this up, but it seems like it's going in and out. Focal segmental glomerulosclerosis. That means that there are many part of the kidney that have that have kidney scarring, which is part of the nephrotic syndrome, membranous glomerulopathy, diabetic glomerulosclerosis. Okay, so nephrotic syndrome, you should always think of either membranous or minimum changes, or usually is secondary to other disease like diabetic. amyloidosis. And as you can see here, these are different kinds of glomerular diseases. Okay? And some of them is lupus or post-strep, Berger's disease. This is associated with immunoglobulin A, which accumulates in the kidney. Okay, and then some of them may associate it with anti-nuclear cytoplasmic autoantibody glomerulonephritis. What does all that mean? Okay. Which really means is, okay, so glomerular disease is classified as either primary or secondary. Primary is usually due to the defect within the kidney themselves, okay? Kidney themselves, like an autoimmune disease that binds to the basement membrane, for example. Secondary is that, something else like diabetic or lupus that could develop secondary, okay? All right, so I'm going to see if I can try to find out why I'm going in and out, but I have made this slide for you. Okay? It is the most important slide. If you need to spend the next 2 days to study or to remember, write it out 10 times if you have to. The difference between nephritic and nephrotic syndrome. Okay, nephritic syndrome, you see red blood cells and red blood cell cast. Low protein, you have, so low protein for me, I would write it as protein plus. That means low protein, right? Whereas you see protein high would be plus, 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 okay, nephrotic. And typically, the nephrotic, you might see oval cells or heavy lipid, if you will. Within the nephrotic, you have focal segmental glomerulosclerosis, minimum changes. In fact, that's the number one causes of nephrotic, if you will. Okay. Number two is membrane glomerulopathy, which is meaning thickening of the membrane. And it's not uncommon that in nephrotic syndrome, it's usually secondary to other disease like diabetes, amyloidosis, or systemic lupus erythematosus. Okay. There are other glomerulonephritis. Part of the nephritic is membrane proliferative glomerulonephritis that you see here. In terms of the nephritic syndrome, complement proteins play an important role in distinguishing different kind of nephritic event. If it's post-strep, because post-infectious or post-strep, typically acute, this is also known as acute glomerular nephritis. And it's usually when people have an infection, they have antibodies produce production. So antibody binds to the antigen, can activate the complement system, okay, which is basically activations of C3 to convert C3 to C3A, C3B, which ultimately convert to C5A, C5B, which is converted to complement with C6, C7, C8, C9, building a membrane attack complex. But when C3 or C4 is low, that is the differentiation between post-strep versus rapidly progressing glomerular nephritis, if you will. Okay? All these terms are not familiar with you, should be familiar with you, right? So I have outlined it for you so that you can start studying them. So if C3 or C4, however, is normal as opposed to low, then the low one you should think of post-strep lupus or membrane proliferative glomerulonephritis. Right? So see how membrane proliferative glomerulonephritis could be either here, nephritic or nephrotic. So you have to distinguish which one is which. In most cases, if it's related to hepatitis C, it is this infection. It will be the nephritic syndrome. But in nephritic syndrome, if C3 or C4 is normal, you have to think of whether the anti neutrophil like cytoplasmic antigen or ANCA presence or not. If it's present, it's most likely it's going to due to autoimmune disease that affects the blood vessel, like the vaginal vasculitis. You don't have to talk about poly um, poly and blood vessel anginas with arthritis, arthritis, okay, or church Strauss. If it's negative, then you should think of rapidly progressive glomerulonephritis. And rapidly progressive glomerulonephritis, you should also think of as crescent. Okay, crescent a Bowman's capsule. Okay? So the Bowman's capsule, if it looks like this shape, like a crescent moon, because you get expansion of that the glomerular cells, okay, something like that. That's what you should think of as rapid progressing. All right, so I'm going to stop here and going to give you guys 5-minute break and look at this glomerulonephritis figure.